Good afternoon, everybody, and happy October. Making our way through this year. This is Dr. Harganani, Chief Medical Officer from the Oregon Health Authority, and I will have Dr. Jean introduce himself, who's joining me today.
Hi, this is Tom Jean, Deputy State Health Officer for Oregon Health Authority.
Great. We are just a force of two today to provide some COVID-19 updates for all of you. As usual, we'll be monitoring the questions that are coming in, share them back out with you, and try to respond to as many as we can today. So let's get started. Today, we're going to give you some updates on what's happening with COVID-19 and some of the epidemiology. We're going to focus in on some testing updates. A couple points of news related to COVID-19 and what OHA is doing. And we'll give a brief literature update on a couple studies regarding treatments before we close today. So getting started, we'll walk through some of the information we typically give you on these webinars. As of yesterday, we had 33,509 total cases of COVID-19 documented, with over 2,500 total hospitalized cases. We continue to see deaths in the state, tragically, and we are up to 559 at this time. Hopefully today you can see the epi curve in the background of this slide, showing some new emerging trends just over the last couple of weeks that we'll speak to on the following slides. As you can see, we had by early September really seen some nice drops in new cases as well as hospitalizations, with some upward trends over the last couple of weeks. So for our weekly update, this was produced yesterday and posted on our website. From September 21st to 27th, we had nearly 2,000 new cases recorded. This is up from 32% from the week prior, so seeing that increase. We also had over 24,000 Oregonians tested during that time period. I will also note that this was a substantial increase. As you might recall, we had fairly low testing numbers during the wildfire emergency. And so we're seeing that testing go back up to more normal levels that we had seen prior to wildfires. During the week of September 21st to 27th, a total of, there was a 6.2% positivity amongst those tests done. And just as a reminder, based on how we're now reporting on test positivity, the number might change as additional test results from specimens collected during that time period are reported. We continually update that data, so you may see fluctuations as we've seen in the past. Last webinar we did with all of you, we had some questions about severity and rates by age group. This again is reported in our weekly report, but we wanted to put this in front of you today just to kind of point you to that data. So first, a couple things I'd highlight here in these yellow boxes. This is cases per 100,000 based on current population estimates, and then case fatality rate at the end. So you can see the highest number of cases based on the population, as we've mentioned before, for now quite a long time, has been the group of 20 to 29-year-olds, and that has stayed steady, I think, for several months now. In contrast, however, the highest case fatality rate is in the oldest population we have captured here, those 80 and over. And that case fatality rate based on known cases is just over 21%. So you can see case fatality rate is at 0% under the age of 40. And you can see the trends that we have here across all of these age groups. I will note, as we shared at our last webinar, we do have a specific pediatric COVID-19 report that dives into more detail about those under 19. So if you want to dig into those first two rows a little deeper, please do visit our website to see that pediatric report, last updated September 15th. Again, we will continue to share some of the disproportionate impacts of communities in Oregon by race and ethnicity. Here, this slide is specifically focused on cases by race. I will note a couple things. There continues to be significant disproportionate impact by race. You can see here that under the yellow row, particularly notable for Blacks, American Indian and Alaska Natives, and Pacific Islanders. As we've shared before, this other category is largely representative of those who identify as Latino, so you will see that on the next slide. Again, those cases per 100,000 are based on current population estimates for each of those racial groups. In the trends below, you can see the trends by race, by time period. And so you can see where we've had increases that you can see align with our epi curve, and you can see what populations are most representative in those changes in the epi curve. Perhaps of note, over these last week or so, you can see an uptick in the cases among whites on this curve in particular. The next slide is focused on our cases by ethnicity. Again, you can see the disproportionate impact among those who identify as Hispanic, nearly 40% of all cases. You again, in this timeline, you can see the differences over time. Again, peaking over the last 2 weeks are more focused on those who are not Hispanic. I will pass this, before I pass this to Dr. Jean, I will just mention one thing. Sorry for my misstatement. You are right that case fatality rate is not 0 if there are deaths. My bad. I did, when you look at the slides again or go to our weekly update, there have been no deaths in the youngest age groups. So I apologize for my misstatement there. So thank you for noting that. There was a question as to whether there was a spike of positive tests as a result of evacuations from fires. And I'll make a comment and then see if Dr. Jean has anything to add to that. I think it's very difficult to know exactly all the factors that have produced the increase in transmission or cases over the last couple of weeks. There are a variety of factors that have occurred that we are aware of. First of all, the time period came soon after Labor Day weekend. We know that over those holiday weekends, we have historically seen an increase in number of cases. We've had some ongoing workplace outbreaks during this time period. We also know that some schools are back in session, as well as some college students back in dorms. So those are all factors that could play a role here, in addition to significant impacts from evacuations on sheltering and doubling up in homes. And we know that that has a potential to play a role. I don't know that our epi data at this point has been able to discern and detail out which of those has contributed the most. Dr. Jean, do you have anything more to add to that?
No, I think that's a great summary. Those are the major factors that we would expect. The other minor factor that could play a role is that with the disruptions from the wildfires, perhaps some people who maybe would have been tested, who were lower risk or less symptomatic or asymptomatic, who might have gotten a test anyway, were less likely to get tested, which is why we were seeing our test positivity go up and our total tests go down a little bit. But yeah, again, the concerning trend right now is that we're seeing both test positivity and cases per 100,000 going up a little bit. But again, not unexpected given the disruptions and the school reopening and the holiday a month ago. So school readiness metrics, we've talked about these before. The one thing I would highlight here is that currently both the state and county test positivity threshold is suspended given those disruptions in terms of school reopening. It's a relatively moot point right now because in most parts of the state and the case rate is well above that 10 per 100,000 that would allow them to fully reopen in that county to in-person instruction. However, the threshold for K through 3 is 30 cases per 100,000, and there are quite a few areas where that is met right now. So we've got some schools that are open, and then of course there are quite a few exceptions. You can see that link in the lower right, the metrics explainer document, which was recently updated, has a lot of exceptions. So we do have schools, especially in rural and remote areas, that are open to in-person right now. So I would just say, if you want to look at our weekly report that was published yesterday, it does list a total of 6 schools, all of them in relatively more rural or small towns that have had recent cases. And then next slide, we'll just see the numbers here. You can see that general trend upward in the past few weeks for case rate, as well as test positivity, as we mentioned.
Question that came up about this, and I'm hopeful I'm not going to lose our questions because my computer is going to restart, so apologies. We'll keep at this. So the question was, what percentage of Oregon students K through 12 are attending 100% in-person classes? Do we have that information?
Yeah, I don't have an up to the minute, but from Oregon Department of Education last week, they had received so all schools were required to submit operational blueprints about what their plans were, and 75% of schools in the state for which they received plans 75% of all schools, which is 1,190, plan to open and are opening in comprehensive distance learning, which means fully remote, and then 10%, which is about 164, plan to open in a hybrid model, so with some on-site as well as remote. And then another 10%, 162, were opening with full on-site learning. So definitely a minority of schools doing the on-site learning, usually under one of those exceptions.
And then one other related question for you, Dr. Jean. Someone commented that they noticed a big increase this week in Lane County. Do we know if that's related to college kids returning?
We don't know. I haven't looked at that in detail, but it's certainly plausible. And I know that some of the zip codes around in the University of Oregon were reported, and the Oregonian is having a very high rate. So it's definitely in the news. So it's certainly possible that's connected to students being on campus.
Great. We'll keep going and come back to some of the questions you shared with us. As we've been noting these trends in cases and percent positivity, we're also following the trends in hospital census statewide. So you can see here, we had been at a bit of a plateau with then a bit of increase in hospitalizations with COVID positive patients over the last 2 weeks or so, hopefully plateauing again. In discussion with hospitals, first I would note that they've been very busy, not necessarily due to COVID, but for other reasons, particularly, of course, impacts due to evacuations, but also a notable increase in some areas in traumas over the last couple of weeks. They're also noting perhaps generally some trends where they're seeing patients who are in the hospital, not necessarily for COVID-19 treatment, but maybe had already had a diagnosis and then come in for a trauma. So some of the trends in our COVID positive patients in the hospital may or may not be related to severe COVID-19 disease. It may be related to just general transmission occurring in the state and needs for in-hospital care for other reasons. But ultimately, hospitals are doing okay on their bed capacity at this time. All right, back to you, Dr. Jean.
Yep, so I have several testing updates today that should be useful, although some of them are fairly preliminary and I can't give you all the details. So the first one is that we have, next slide, we have submitted an update to our testing recommendations for healthcare providers. That's our our clinical testing guidance. And this is going to go live early next week. So stay tuned, but the main change that we anticipate, and I've been involved with this, but we can't can't be confirm it until it's official, but the main change is going to be that it's going to align our guidance with the recent CDC update recommending testing of all asymptomatic contacts of a COVID-19 case. So it's going to be a much more explicit recommendation to do that, we anticipate. So stay tuned. That should be out early next week. Secondly, I wanted to highlight a new guidance document that we published on September 21st. I don't know how many providers on the call are connected to a long-term care facility, but even for those who aren't, I think this is important to look at or be aware of. And basically, this is highlighting the use of point-of-care antigen tests in long-term care facilities and recommendations for molecular testing versus antigen testing. So PCR is generally what the molecular testing would be, or something like the Abbott IDNOW versus the point-of-care antigen test like the Quidel Sofia 2 or the BD Veritor or the new Abbott BinaxNOW. So the general recommendation, and you can look at this document, the links available at the bottom. The general recommendation is to test asymptomatic residents and staff in facilities that don't currently have an outbreak. And that's kind of aligning with ongoing testing required by Oregon's long-term care facility testing plan or the CMS long-term care facility testing requirements. And then for symptomatic residents, they should be tested with antigen test and then a PCR follow-up if antigen is negative. So that's for facilities that do have access to molecular testing. For facilities that don't have access to molecular testing, or they don't have a rapid turnaround, which is defined as 48 hours, they should be using point-of-care antigen testing for all symptomatic residents and staff without a follow-up because they don't have access to it. And then they should be testing asymptomatic residents and staff if there's an outbreak in their facility. So that's kind of the summary. If you go to the document, there's actually a whole flow chart and more information there. This is a slide just to remind you of what the 4 FDA EUA antigen tests are. And you can see there that the Abbott BinaxNOW is the one that I'll say a little more about, but that's the one that's point of care and does not require a machine. And it's a nasal swab, it's just a card, but it does require a CLIA waiver and a medical professional. So on Monday, there was an announcement from the White House, and this is kind of the summary. We've already deployed nationwide 50 million rapid point-of-care antigen tests. That's the Abbott BinaxNOW. And I think that's still happening, and these are being deployed to vulnerable populations, natural disaster, impacted people, nursing homes, long-term care, historically Black colleges and universities, and Native American communities. The update is that 100 million of these tests will be distributed to governors around the country free of charge over the next several weeks. And states will be responsible for distributing and administering the tests as they see fit. So much more information will be coming on Oregon's plan for these tests soon. And we'll be receiving the tests. We will be working to distribute them mostly to outpatient providers with a focus on disadvantaged populations. Next slide. Just showing you what the test looks like. That little pink thing is the card, and then there's an app involved too, and it is a 15-minute turnaround. Does require a medical professional and a CLIA waiver, so it can't be done just by at home. And then the app does not report to the state, and it has this 5-day pass with a little QR code. We have some concerns about that, but we are evaluating it, and we'll update more on our recommendations soon.
Question, Dr. Jean, that came up about testing. This is related to the anticipated updates to the healthcare provider testing guidance document early next week. Mm-hmm. The question is, will that testing guidance recommend testing for healthcare workers if they were wearing appropriate PPE, but otherwise meet close contact definition, less than 6 feet away for more than 15 minutes?
I believe that's already the recommendation. So PPE really doesn't change our official definition of exposure, especially if we're talking about the provider is the one with the case versus a patient. So it still comes down to 15 minutes within 6 feet.
I think in this question, perhaps then the opposite, if the patient was the positive patient, but they were wearing appropriate PPE, would that healthcare worker need to get tested?
I think that is, I'm not entirely certain. I think that's in our clinical and healthcare prevention guidance in there. That's something that you'd want to work with your infection preventionist at your facility or your hospital if you have one.
So we will make sure these questions are really good ones and that they're really clear in our upcoming webinars and of course in the guidance. So great questions.
Yeah, it just gets so complicated with all the different permutations of here. But in general, PPE is, we know it's very effective, but it doesn't always change what we consider an exposure.
Great. One other question, sort of related, is anyone tracking whether people who inconsistently wear masks, this is general population, are more likely to test positive? Is there evidence to reassure people who are wearing masks that it works?
That's a great question. I haven't looked at the latest literature on that. So I don't think I can answer that definitively right now. Have you seen it?
I know that our senior health advisors have looked a lot at some of the emerging evidence around masks, so I think that's something we can bring back for next week. Certainly, I think we have suggestion from the trends in our transmission as masks became required. And so I think the trends are suggestive, but we can come back with some more of the specific evidence where it might exist to be able to support those who want to know.
Yeah, I haven't been aware of a lot of studies. It's a little bit hard to study that, but I think as time goes on, we'll hopefully see more evidence.
We would definitely encourage you, however, to continue to strongly recommend to your friends, colleagues, patients about the importance of masking. Of course, good evidence behind that would be helpful, and we'll see what we can find for you.
Yeah, it's the kind of thing that we don't have, randomized controlled studies, but there's lots of other levels of evidence that support mask wearing, not only for COVID-19, but for respiratory viruses in general.
Great. We will keep going and come back to some more questions.
Okay, yeah, this was about what I mentioned briefly a little bit before, but as of this week, in our weekly report, we are now reporting all COVID-19 cases in schools. So that's, just to be clear, that's all cases, it's not just outbreaks. So even if a school has only one case in a student or a staff member, they will go up on that list. This was a decision made with our, in consultation with ODE as well as the governor's office. So there'll be a whole list there in the interest of transparency. And of course, if there is an outbreak or an exposure to school, that school will be working with their local public health authority and their community and the parents and staff to inform everybody of any risk, any need to quarantine or a potential closure. So that's the primary thing. But for statewide, there will be this list. And as I said, there's currently 6 schools on that list. So it's published every Wednesday in our weekly report. There is information on the ODE webpage where it will also be reported. This applies to all public and private schools, and it's just, again, in the interest of full transparency. For reporting purposes, we're treating schools without students being served on site as workplace outbreaks. So just an example of what that would be, say you have a bunch of cases in a school determined to be, a school property where there are staff that are perhaps doing remote learning from school, but there's no students on site. That would be considered just a workplace outbreak and would be meet our criteria. It would have to meet our criteria of 5 or more cases in a school with 30 or more employees. So we'll see. I'm not aware of any of those being reported yet.
Dr. Jean, question related to school reporting. How does this work for colleges?
All this stuff that I'm talking about is for kindergarten through 12th grade. So it's not currently applying to colleges and universities.
Okay. All right. A couple other updates from OHA we wanted to mention. Probably about a month ago, I shared that OHA had announced up to $45 million available for applicants regarding health equity grants. And we just, at the end of last week, announced those who are receiving funds from this grant opportunity. Ultimately, OHA has funded 205 nonprofit organizations and tribal governments with grants totaling $45 million. As I had shared before, these are really focused on supporting a variety of needed resources, really consistent with social determinants of health, things like economic disruptions, food insecurity, housing, safety and violence prevention, and many other that were identified as needed resources among communities who are most disproportionately impacted by COVID-19. So we are thrilled to be moving out these funds to these organizations and to be meeting the identified needs of these communities most impacted with COVID-19. I invite you, if you would like to learn more about these, feel free to check out the website I have listed here. And in addition, you can see the full list of awardees of those 205 organizations and tribal governments, which really span the entire state. So we're excited about this announcement and welcome you to take a look. Another important topic I wanted to make sure to bring to this webinar, we've been doing other work to make sure this information is getting out to everyone who needs to know, but this opportunity here is to share with you the importance around real D data collection and reporting and some new requirements as required under legislation that passed earlier this summer during an emergency legislative session. So as we've spoken to repeatedly here, we recognize that tribal members, communities of color, and people with disabilities have been disproportionately impacted by COVID-19. Collection and reporting of data related to race, ethnicity, preferred spoken and written language, English proficiency and interpreter needs, as well as disability status, is critical for us to understand the disproportionate impact and potential needs of these communities. This provides OHA and the Department of Human Services, among others, with granular data to better address those disparities and inequities, such as what could be seen in service delivery, like testing, treatment, and ultimately vaccination down the road. So House Bill 4212 just passed, as I said earlier, this summer. In sections 40 to 43 required OHA to adopt rules requiring healthcare providers to collect real D data for all COVID-19 encounters and to report this data to OHA if you are a provider that's generally required to report under organs disease reporting rules. So for example, if you're required to report on certain infectious diseases according to state law as a provider, you would also be required under this new legislation to report real data for all patients if their encounter was related to COVID-19. A little bit more on the data collection requirement. So at the time of an encounter or as soon as possible thereafter, healthcare providers must collect this data called real D data. And we are sharing a lot more information about that data collection requirement. There's very specific requirements about how that data is collected and what data fields are collected on. So we invite you to take a look at this on our website. We are also teaming up multiple webinars and trainings and learning opportunities should you need more assistance in understanding this requirement from healthcare providers in Oregon. So some of the requirements on reporting by healthcare providers. So this bylaw went into effect today. There is some tiered reporting requirements. So not every healthcare provider is required to report immediately starting today. The focus initially are providers who are part of a hospital or health system, as well as federally qualified health centers at this time, with rolling out to other providers over time. All of that can be found on our website. At the beginning of this reporting requirement, up until October 1st next year, providers must report the data to OHA. For example, at the time a COVID-19 test is ordered, or when you're reporting COVID-19 information as required, such as through that based on an encounter having occurred, And you must do that through one of the following ways listed here. Through our online reporting system, by fax only if that online reporting system is not offerable, or through direct electronic case reportings. We'd have to get that approved through OHA in advance, and also through clinical laboratory reporting. In a year from now, it will be expected that healthcare providers are reporting that through electronic initial case reporting, through basically EHR systems and beyond. We know there's a tremendous amount of work to get there. I know a lot of hospitals and health systems and providers are working on that, and OHA will be providing a lot of support to get there. While we know that this initial phase is going to be very time intensive, the legislature has felt that this is so incredibly important given the limitation in what we understand about the disproportionate impact on populations in Oregon, that this is a priority, and therefore OHA again has moved forward with these rules after a large public input process over these last couple months. Again, if you want to find more about disease reporting requirements, who's required to report, you can check out this website. We have much more information rolling out as we speak and expected to be posted even by the end of today, including frequently asked questions, training opportunities. There will be an exception or an extension process. It will be limited, but there will be availability of that. It will outline more about the enforcement and what that will look like starting in the end of December. I've given you a contact note here should you have any initial questions, and please just keep an eye out for all of these trainings and FAQs coming out. We'll keep you posted in our future webinars. And I know there's a lot of concern about the impact in terms of time and capacity for this reporting, but this has now been formally put into rule and again required by OHA based on legislation passed. And so other than the outline of a potential extension opportunity, which will be limited, this is something that does have to move forward. So we really thank all of you for the time and effort that will be put into this, and in particular for your work in helping us to understand and address the disparities being experienced in Oregon. Moving on to a couple COVID-19 literature updates. There's just a couple of studies. I will note here that we were appreciative that Dr. Schmitz was able to actually do some of these reviews for us. I have quickly gotten myself up to date, but not as expert as she was but was unable to join us today. So a couple of updates here on some studies related to emerging treatments. So this first is a meta-analysis of Tocilizumab. This meta-analysis, which is in press right now, looked at 10 observational studies, including 1,358 patients, 554 patients who received this treatment, and 804 who did not. And it looked at the endpoint of mortality, and this meta-analysis found that mortality was 12% lower for COVID-19 patients treated with Tocilizumab compared to COVID-19 patients who weren't treated with this. Tocilizumab, just for your note, and hopefully I am saying it properly, is an interleukin-6 receptor antagonist. So the questions were, does this therapy reduce mortality in COVID-19 patients compared to those not treated with this IL-6 receptor antagonist? And is there an increased risk of side effects compared to patients not treated with it? You can see here down below the risk ratio, which is defined as the risk of the Tocilizumab group compared to the risk of the control group, was 0.27 with, you can see the 95% confidence intervals listed here. And ultimately, the data suggests that for every 11 severe COVID-19 patients treated with Tocilizumab, 1 death is prevented. And there were no differences observed in side effects. Of course, as the authors also noted, given the observational design of the included studies, these should be interpreted with caution and require confirmation by randomized control studies, but will be useful to continue to monitor the outcomes of this treatment. The next systematic and review shared here is related to, this one is hard for me, Favipiravir, and I'm going to call it FVP from now on. This, again, was another systematic review and meta-analysis. It included a variety of different study designs, requiring at minimum a number of 5 patients in each trial, so included randomized controlled trials, prospective and retrospective studies, and beyond. So there were a total of 13 studies. And one of the things that they looked at was significant clinical improvement, including radiologic improvements in CT scan. They were also looking at outcomes of clinical deterioration at 1 week and 2 weeks after treatment. And so it was they found that those treated with FVP showed a significant improvement in clinical outcomes at the 14th day compared to the control group. There was no significant differences found on a variety of other factors, including the need for non-invasive ventilation or oxygen, and no differences for adverse effects. There were, it was noted during looking at, while they did this review, that there are currently 31 randomized controlled trials registered in different parts of the world looking at this treatment, this antiviral treatment for COVID-19. And so we're likely to be learning more about this over time. And then finally, one last look, perhaps, at treatment with hydroxychloroquine. There are 2 studies we just would give attention to. The first one is a meta-analysis looking at 6 studies and 381 patients treated with hydroxychloroquine for treatment of COVID-19. As had been suggested through literature reviews we've shared before, groups treated with hydroxychloroquine had an overall mortality rate that was 2.5 times greater than that of the control group, and overall higher rates of adverse clinical outcomes and side effects compared to the control populations. So additional ongoing information suggesting that this is not an appropriate treatment due to the risk profile of this medication. Also here is a different study. It was a RCT looking at the use of hydroxychloroquine as a pre-exposure prophylaxis for hospital-based healthcare workers. You can see here there are a total of 132 participants looking at the use of hydroxychloroquine versus placebo over an 8-week course. There is no significant difference in infection rates in the participants compared to placebo, and the study was terminated early due to futility. So that is maybe the end of that story for now. So I'm going to look at some of these questions here. Anything you'd add to those studies, reviews, Dr. Dean, that I missed?
No, nothing.
Okay, looking at some of your questions here. There's a variety of different things. Just scanning for a second to capture. There's a couple questions. I'm going to try to broadcast those for you all. A comment asking about the potential for extension for COVID-19, or sorry, for REAL-D data reporting. And as I mentioned, there is going to be an extension process. We should be posting that form today. There is not going to be a broad extension. And one thing that I know the form is going to indicate is that the extension will not be approved on the basis just that it's not in the AHR system, because we know that broadly that is not going to be possible immediately. So again, we appreciate your efforts on this, recognizing the time impact, but really the opportunity here. There's a question if we are the only state taking this move. I actually don't know the answer to that. I can report back as I learn from our subject matter experts on REAL-D. And there's a question about how this REAL-D data gets put in the OHA database, what happens to that data. There's been a lot of efforts underway. I don't know all the details to be able to share with you exactly how all that data gets captured and reported out. Certainly, it is absolutely our intent to improve our analysis and reporting related to REAL-D And the data that is provided through healthcare providers will be very helpful to that set of goals. During contact tracing and interviews, I know that those interviews include real D data collection to the extent possible, and that improvement has been happening during the course of COVID-19. I also know that there are multiple local public health authorities who are also collecting real D data specifically in their work and reporting on that, such as some of the local Tri-County metro area public health authorities. So a lot more to come, and a lot of community partners, particularly those representing communities of color, tribal communities, and those with disabilities who are particularly interested in this and analyzing this data with us. So thank you. More to come, and I'll keep sharing what I can on this topic. The question is, are patients able to decline to provide real D data sharing? I'm certain that the answer is yes, but there's a lot of tools and even training tools, things that you can use to help answer questions that might come up about why you're collecting that data, et cetera. Again, that will be a lot of the training materials that are already available online, as we've been collecting real D data in many different ways over the course of time. So those questions about someone who's wondering about it or so forth, or maybe ways that you can indicate the importance of the data, those tools are available to you, and we can make sure we could get that. I am noting someone says that the sound is gone and they cannot hear us. I'm going to ask Dr. Jean to just maybe check with our tech person to see if that's the case. It could be that it's just a real, I mean, an individual person's problem, but if you want to, I guess I can't ask you to do anything if you can't hear us. If someone is hearing me, please just send me a note so that we are trying to identify if this is a broader issue. Looking at some of the other questions here.
So, yeah, apparently he's dropped out here too. So.
Okay. We are just on hold for 1 minute while we're trying to see if we have a, I'm not sure, Brent, if this is just one person's.
I can't hear it on my headphones anymore.
Oh, I'm still hearing, people are saying they can hear us.
Okay.
Thank you. It's back. We're good.
All right.
Thank you for all the notes. Okay, we'll keep going with some of your questions. So Dr. Jane, a question for you. It says, what are the metrics for schools that close CLATSIP to be able to reopen?
Yeah, so the metrics are a little bit complicated because we tried to build in lots of flexibility for different school settings. That metrics explainer document that ODE put out was linked on the school metrics slide, and that kind of goes through all the exceptions. So if a school is the first page has the basics. I'm sorry, I can't pull it up for you, but basically we've got for the general criteria, there's that 10 cases per 100,000 in the county, and then a test positivity of less than 5%. And those need to be met 3 weeks in a row to go back to in-person instruction. And most counties are not there. And so, but if they did get there, there are some specific metrics for how they would have to return. If they get above, for example, 30 cases per 100,000 or a test positivity of 10%, they would have to go to full comprehensive distance learning. So separate from that, and this may be what the question is about, there are a lot of the smaller counties that have specific exceptions. And that would be, for example, the total number of cases is less than 30, not the case rate. The total number of cases in the last 3 weeks is less than 30. And so if a small county, schools in a small county open under that exception, it's actually not, once they open, they don't have to then suddenly go back to remote if they go above 30 cases. There are some specific things that basically the local public health authority will work with the school to determine if there are any, if there's community spread, or if there are significant cases, more than, I think one of the criteria is more than 2 cases in different cohorts. that are in that school, and that would be a criteria to close. So the short answer is once you reopen, according to one of those exceptions, you don't have to stick to that reopening criteria, the reopening exception. In other words, you don't have to instantly go back if you go above that number. You work with your local public health authority on a case-by-case basis to make sure there's no significant spread or risk of transmission.
Great. A couple other, these are not all directly related to one another, but I'll just go through some of the questions I'm trying to catch up on here. One question, and I'm not sure if you know this, Dr. Jean, when people are identified as a case, actually a case contact, are they asked if they were wearing a mask or if they were a case, I guess, on case interviews or case contact tracing?
I think that is, yeah, that information is elicited, but it's, again, it's a little bit challenging because we do know that even cloth face coverings reduce the risk of transmission, but if it's not medical grade PPE, that generally doesn't affect what we determine to be an exposure. So 15 minutes within 6 feet, even if you're wearing a face covering, would generally be considered an exposure. But that doesn't mean the face covering didn't reduce your risk. We just think that it's not enough to say that it's not an exposure.
And then earlier when we were talking about testing guidelines, you had mentioned, Dr. Jean, that there's clinical and healthcare prevention guidelines, and they're wondering where those can be found.
Yeah, so if you go to the, if you see that link that's on the screen right now, the top link, healthoregon.org/coronavirus-HCP, that takes you to our healthcare provider page. On that page, there's a section, there's like an accordion that pops out for healthcare providers specifically. And under that, there's a link to, let me just pull it up here. The document is called Clinical Care and Healthcare Infection Prevention and Control Guidance for COVID-19. And that's the document I was referring to. So in that, regarding that previous question about whether an exposure, there's an exposure for a healthcare provider who's wearing PPE, I think this is a little challenging because usually in a larger health, like a hospital or a clinic that's part of a larger health system, their infection control and prevention folks are generally in charge of work exclusion and determining exposures for their staff. And there is specific guidance in here about what is really considered a high-risk exposure that you would exclude a staff member for. So if you're working with a COVID patient, you're wearing all the proper PPE, that's generally not going to be considered a high-risk exposure, and you're not going to need to be excluded. You're not going to need to quarantine. But there is some specific language in there on what is considered a high-risk exposure. And that would be things like providing patient care that included an aerosol generating procedure without the full PPE required for that, respirator, eye protection, gown, and gloves. Or providing non-AGP, non-aerosol generating procedure care to an unmasked patient, and you're not wearing a face mask or respirator or eye protection. And then finally, providing regular care without AGPs to a masked patient, even without a face mask or respirator. So those are things that really should not be happening. Providers should be wearing, and in most cases, it's universal face masking or N95s. But those higher risk exposures would count for work exclusion in general. I hope that helps with that question.
Another school metrics question, and I think we both acknowledge that these are pretty complicated, and it's trying to be flexible, again, for many different scenarios. But this particular question is related to children with special needs. So it says, my understanding is that for children with disabilities, they can have 2-hour per day small group in-person instruction limited by total contact time of the teacher. Are there any metrics that preclude that?
Yeah, so this would be the kind of the first exception, which is limited in-person instruction for specific groups of students. So that would include students with disabilities, English language learners, and then some things like career technical education that requires hands-on kind of in-person learning. So the main requirements there is that if the school has been open, there haven't been any confirmed cases among that school's staff or students in the past 14 days. And then otherwise schools, so that's the main bar. Otherwise schools just need to make sure they're fully complying with the Ready Schools Safe Learners guidance, and they're fully following the comprehensive distance learning guidance for limited in-person instruction, which does have those limitations on the cohort sizes, the time, and more. So that's really the only requirement there, and that's the reason for that. It's a relatively low bar, is that kind of in-person instruction is really crucial for those specific groups of students, including students with disabilities. And you know, in most cases, it's a relatively small population that's going to be doing the in-person, so smaller cohorts will be quite feasible.
Okay, a couple questions. Is OHA recommending universal eye protection for all employees in healthcare settings in all interactions? For example, face shields or goggles?
I believe so. Again, I haven't been directly involved. It looks like that I think that was one of our changes. I'm just looking at the document. Again, that's that clinical document. Wearing eye protection in addition to a face mask or an N95. Yeah, that's listed as a universal measure to protect those in healthcare settings. So I think that is the recommendation here. Especially, okay, so long-term care settings. Okay, so sorry, I was just refreshing my memory here. So for staff, healthcare staff in long-term care settings, due to the increased risk and the likelihood of close contact exposures, long-term care facility staff should wear a face mask and eye protection. Healthcare providers in other settings, so that would be hospitals and clinics, etc., should consider the addition of eye protection. So it's a recommendation that you consider it. It's not a absolute requirement or absolute recommendation. And that'll especially be more important in scenarios where patients are unable to wear a face covering.
Another question, and I know this has been one that there's been lots of discussion around lately, Dr. Jean, and I'm not sure what's been updated on this. It says, in a workplace situation, if there are more than one worker known to have worked who then was COVID positive, what requirement to report does the employer have?
Can you say the first part again?
So this is in a workplace situation. If there's a worker who became COVID positive and had worked during that time period, what requirement is there on the employer with regards to reporting?
So, if there's so in those situations, I think generally our guidance beyond just COVID is the local public health does contact tracing, and they notify the employer or vice versa. So the employer is on the same page, and they work with the employer to find out what other employees were actually exposed, considered exposed contacts. And then they would make sure that the employer is working with all their employees to notify those. I don't think there's a blanket recommendation that they would have to notify the entire facility necessarily. It's really just finding who the people at risk are. And then separately from that, if there are more than 5 cases in a facility with more than 30, I believe, that's where it meets the criteria for public reporting, and it goes on to our big list of workplace outbreaks. But in general, we kind of follow the guidance of, who needs to know. It's a need to know basis to protect privacy. So again, it's finding who's actually at risk, and it's not necessarily notifying everybody until it meets that 5 case threshold.
Great. I'm trying to publish some information on the RealD learning series coming up, as well as the RealD website. So hopefully you guys everyone was able to see those that I just posted. And I think we probably can take 1 or 2 more questions, and I'm going to scope through here on something that I might have missed. 1 minute. There was a question about there's a comment about the concern among staff about the risks when doing, see, I'm trying to find it again, risks regarding taking temperatures on the risk about exposure. And I cannot seem to find the question again, but it was, I think, asking about the effectiveness or accuracy of using digital or other thermometers to reduce that close exposure. Have you followed any update? I know there's been various concerns over time about the accuracy of thermometers, and I'm not sure that I'm up to date on that.
Yeah. Temperature screening is not something that OHA has recommended in most situations. It's, first of all, even from early on in the pandemic, we were seeing reports out of China and other places that very significant, I think it was something like 40 to 50% of COVID positive patients did not present with a fever. So fever is not a very sensitive a sign, and it's not very specific, of course, because there's lots of other things that cause fever. So we generally have not recommended that. There are also separately concerns about the accuracy of some of the temporal thermometers. I think there's just a lot of variance, some between different brands of thermometers and types of thermometers, and oral versus temporal or axillary or what have you. So in general, we have steered clear of recommending that. And of course, there are some concerns about close exposure if you're taking temperatures on a ton of people. So I know a lot of the healthcare facilities in Portland, for example, are doing temperature screening of all people who are coming in for appointments, and that's certainly their call. But we think it's relatively low yield, so we haven't recommended it. For example, in schools, we are not recommending they screen all students for temperature. They screen them for symptoms, make sure they look visibly healthy, they're not coughing, and they ask them if they've had symptoms, and parents are asked to report if their kids have had symptoms, but we're not recommending temperature screening. And then the exception would be, not an exception, but if a parent has taken their child's temperature and they had a fever, then we would say please keep them home, of course.
All right, maybe time for one more question here. I think it came up twice, so I just want to throw it out there. What is the best COVID test for screening purposes that's currently commercially available?
Great question. Well, you may be surprised to hear that none of the antigen tests, and few to none, I'm not entirely certain, there's now over 200 tests that have received the FDA emergency use authorization, but none of the 4 antigen tests, and the antigen tests are the rapid tests that everybody is talking about using for screening, none of them has been validated in asymptomatic populations. When we're talking about screening, we're basically talking about, you're talking about asymptomatic populations. So as opposed to diagnosis of somebody who's sick. So that is concerning. The federal government, when they've talked about those BinaxNOW, they are talking about using them for screening, even though we really don't have any evidence on their sensitivity or really the effectiveness of using that. So I think we need much more study of that, because that is certainly a potential use of these that we would all like to use at some point. But when we don't know the performance of the test in asymptomatic populations, it's hard to make clear recommendations on that. And as Oregon gets a whole bunch more tests through this federal allocation, we're going to be looking closely at how we could potentially use that for screening. But initially, it's going to be focused on the people with symptoms and the people with very, who are of a higher pretest probability, namely contacts and people who are in congregate settings, especially.
Great. Well, we are just about at time. I just wanted to make one note. Now that we're here at October 1st, I will note that there are actually 5 Thursdays in this month. We are not going to host a webinar on that last Thursday, but there will be 3 other learning opportunities during this month. So as we've been happy to have the opportunity for these Project Echo sessions on COVID-19 will continue twice this month, second and fourth Thursdays in October. So please tune in and register if you haven't for those. There are some great sessions upcoming. Moving into November and December, there will be once a month Project ECHO sessions before the part 2 ends for the COVID response. In October, we will have another webinar on the third Thursday. We will just not host one on the 5th webinar. And we'll keep you posted. We're gonna just reduce ever so slightly our webinar frequency in November and December also, and we'll update that for you when we join you again on the third Thursday of this month. So again, every Thursday this month, except for the last one, you'll have either an opportunity to join us for an OHA webinar or for Project ECHO. Things will change slightly in November, and we'll keep you updated as we get closer to that time. As always, thank you for all of the efforts and all that you do on the front line. And we look forward to joining you again soon. Have a good day.